If you're a golfer, which many that listen to this show are, the chances of you having a back issue at some point during your playing career are probably very high. This isn't necessarily a direct result of golf, as the population in general seems to suffer from back issues of one kind or another. Um, but playing golf regularly, or for people who play for a living, the golf game and the golf swing definitely take their toll because the forces and the torques that the back goes through in a golf swing are exponentially more than the back was designed to handle. At some point, you probably might seek medical advice, be it from a physical therapist, a trainer, or even a doctor. And for the unfortunate few that have damaged their back or experience high levels of chronic pain, you probably might even consider surgery. If you're lucky, you may even have the chance to talk to someone like my guest today. He is a pioneer in the back and spinal surgery industry, and many consider him to be the best in the world. But his genius doesn't stop with the back in general. It expands into specifics, especially when it comes to disc replacement. His name is Dr. Richard Geyer, and he is the co-founder of the Texas Back Institute and Center for Disc Replacement in Plano, Texas, where he has been helping people rid themselves of chronic pain and get them back to an active lifestyle for many, many decades. Not only is Doc Geyer an unbelievable caretaker, but he is one of the kindest and most amazing people that you're ever going to come across. And I trust I was able to bring that forward in today's show. But I'm not really sure he needed me to illustrate that, as just listening to him, his thoughts on life, the care he provides, and his career will probably illustrate that all on their own. It's not often that you get to sit down and talk to one of the best on the planet and discuss their expertise, and I consider myself very fortunate to have gotten this opportunity. I hope that you enjoy listening and learning from what he has to say, and should you ever need a miracle to rid yourself of any sort of chronic back pain, he should be the first person that you reach out to. So please give a big, big Golf 360 welcome to my guest, the world-renowned spinal surgeon, Dr. Richard Geyer. What's up, everybody, and welcome to the Golf 360 podcast. I'm the host, Pete Popovich. So you may be asking yourself, what is Golf 360? And Golf 360 is a show that was designed to introduce you to people associated with the game of golf to help you improve not only at your game, but also your life. Almost all of our guests are from within the industry in some way, shape, or form, but some of the guests we have are from outside the industry, and it mainly revolves around the business world with a few others scattered in here and there. Now, all of the guests that we have a few things in common. One, they all were highly successful and accomplished in their field. Two, each has something to pass along that will help you in your game and your life. And three, they were all more than willing to give back by passing along the things that they used to help them in their career, and even some of the mistakes that they made so that others don't make them in their journey. So I hope you find listening to them as enjoyable as I did interviewing them, and that each and every one of you benefits from the information that they so willingly and graciously pass along. This episode of the Golf 360 podcast is brought to you by Affinity Wealth Management Group. We all work exceptionally hard for our money, and none of us can afford to let that fall into the dark abyss of the big box financial service firms with their jack of all trades and master of none mantra, which basically means you become a number within a cookie cutter model, which is often accompanied by massive fees. Your future deserves more than average returns, and at Affinity Wealth Management, they ensure that your financial goals receive highly individualized, tailored attention from experts who are in the industry to be great and not average. As a client of Affinity Wealth, you will receive a customized solution to your customized life, keeping in mind your family's financial situation, values, and risk tolerance. Contact them today at 248-840-3863 or www.affinitywealthmg.com. This podcast is brought to you in part by Just Thrive Probiotic. You may be surprised to learn that your digestive system is the key to creating and maintaining the quality of your physical, mental, and emotional health, and it's one of the body's most essential systems. That's why the majority of nutritionists today highly recommend probiotics as an indispensable nutritional supplement. As a discriminating consumer, you've probably been searching for a probiotic that is proven, potent, and effective, and you found it. Just Thrive is your best choice for maintaining a healthy lifestyle. Just Thrive Probiotic captures the power of hundreds of thousands of years of nature's design with a specialized bacillus strain formulation that guarantees survivability through the stomach and upper digestive system. Supports optimum gut health, digestive health, immune health, and delivers antioxidants. Great for adults, kids, and the whole family. Use promo code GOLF360 at www.thriveprobiotic.com for 10% off your order. Okay, I am very excited and very fortunate and happy to have one of the best back surgeons in the world on today's show, and that is Dr. Geyer. Doctor, thank you very much, especially this time of year, for making the time to come on.
You're very welcome, Pete. It's my pleasure.
One of the most simple things, as I've talked to you a couple times in the past, and I've watched you speak on like Dan Hellman's series that you guys did when COVID started. So one of the most simple, but it's one of the most important mantras or rules that you live by, and that is the family test, which I think is amazing and awesome. Can you just tell everybody who might be introduced to you for the first time what the family test is in your practice?
Well, certainly. Basically, the family test helps to guide myself, and there's many surgeons also live by it, to make the proper decision for a patient, because it's very easy today, and things have gotten crazy in medicine. For example, the reimbursements have gone down, expenses go up. So there's a lot of surgeons out there that, they're running and gunning at, 80 to 100 miles an hour, and they see pathology on the x-ray and they tell a patient, well, I think you need this and this. But in reality, if you really take your time and you just sort of dial things back and you say, well, I see this and I hear the story about, their pain and what's going on. And the family test comes in when you make that decision. In other words, what would I do if this patient was my brother, my sister, my father, my mother, or a friend? And I think what it does, it keeps you honest, because a lot of times we have a lot of pressure in practice. You're seeing a lot of patients. A lot of people are tugging on your arm sleeves and, Dr. Geyer, can you answer this? Can you do that? But I think you have to come back down to earth and to make these decisions really based on sound decision making, and not because you're in a rush, but because you're trying to make the best decision for that patient. And in addition to the family test, and I think this extends to any decision I make for a patient, I make my decisions for a patient, and it's a mutual thing. We talk about it and decide what's the best thing for them. But I'm also thinking about what happens to them in the future, and what happens to them in the future, meaning that if I do this surgery, what are the expectations in the future? Some of the surgeries we do, you do a microdiscectomy, take the pressure off of the nerve, and usually that patient's going to do well. They may have a recurrence, and they may not. But if we're doing a fusion surgery or an artificial disc surgery, this is a long-term deal with the patient, meaning that I see these patients a long time. I try to see them on a yearly basis, but human nature is that if you're doing well, you never come back. And if you're not doing well, you keep coming back and coming back. So in summary, the family test just keeps me honest as a surgeon, because it's very easy to look at an x-ray, but you have to correlate the x-ray with the patient's story, with their physical examination, with pathology, and with the implication what you're going to do to them, or with what you're going to do to them will have on their future health. So it's a long-winded way of saying that you want to do what you would do to your patients, the same thing that you would do for your family.
Yeah, and it's to some listening, it might sound very simple, but if you look at the rest of the world, and as you alluded to, where you have people pulling on your sleeves, whether it's other doctors or nurses or patients or family members, or we're in today's information age, we're bombarded, and attention is such a valuable, and time are such valuable commodities that we deal with, and it's so easy for people to just say, well, I'll just take the easy way. And from all the people that I know who have either worked with you or dealt with you or know you in some way, shape, or form, have said that you have held that commitment and have not ever wavered from that. at all through the entire time that they've ever known you, and some of them have known you for quite some time. So I think it's as crazy and as bad as it sounds. It's a very it's a quality that is not rampant in our society today, and it's just so nice to hear somebody that does that and has and is at the level that you are. You haven't taken shortcuts to get where you are.
You know what, Pete? It really applies also to general things in life as well. If we really treated each other the way we'd want our family to be treated, I think we'd have a much better world. But
Mm-hmm. There's no doubt about that.
how how I started in medicine, just with the love of people, and to treat people, just the way I want my family to be, and I've done this my entire career. And there's nothing that makes me feel worse about medicine when a patient tells me, "Well, I saw Dr. Joe Blow, and he looked at my X-rays and said this is what I need," and walked out. And that's, the patient says that because they're trying to make me feel good, but it actually makes me feel bad. I feel bad because I don't want my specialty to have that reputation. But unfortunately, doctors are no different than anybody else, and it's not a large percentage. I would say most docs are really, trying to do the right things and make the right decision. But in spine surgery, it is an area where there's a lot of gray zone decision making, and that's why I think that something to keep you grounded and keep you honest with your discussion with the patient is really, really important.
Yeah, that's interesting because I knew Dr. Peter Lamott, and Doc Lamott in our area in Hilton Head was famous because he was the founder of the Hilton Head Hospital. But before he moved to this area full time, he lived in New York, and he was, if I'm not mistaken, at one time he was the team physician for the Mets and the Islanders, so the baseball and the hockey team. He was the orthopedic surgeon for them. And I asked him one day, I said, because he was extremely successful, and I said, well, whatever prompted you to get into medicine? And he said it was simple. I wanted to help people, and that was the best way that I knew to do so. Your career path, was it for a similar reason, or was there something else that led you to gravitate towards being in medicine and then ultimately to being an orthopedic and back and spinal surgeon?
Well, Pete, it's kind of an interesting story because when I grew up, my father was a general practitioner, and then he went back and did his residency after he was in practice for a number of years. And I grew up in a small town outside of Philadelphia. It was called North Wales. It had all of about 3,000 families, and you talk about, growing up on the other side of the tracks. Not really, but our house was three houses down from where the Reading Railroad Station was, and it went into Philadelphia. So he had a general practice, and the way he was, keeping going was that he would see patients at night and on Saturdays while he was doing his residency. So I used to tag along with him. I was a little kid, now I don't know, 5, 6 years of age, and he used to bring me into the room and while I told the patients, and of course they see a cute little kid, and they would, say, "Oh, how nice! What do you want to do?" And
Mm-hmm.
and I would just follow him around. And I don't know whether it's genetic or whatever, but I decided way back then when I was a little kid that I wanted to be like my dad. I wanted to be a doctor, and I saw the way he treated patients, and just his demeanor and how grateful they were. And this was at a time where insurance wasn't as crazy as it was. People used to pay him in food and all sorts of things, and he used to actually make house calls. Believe it or not, that is a rare bird. And I would go there and I get my milk and cookies while he was taking care of the patient. And then because he worked in a small hospital, he used to take me there. I think I was 12 years old the first time I went into the OR. And he said to me, he says, "Hey, Ricky, listen, I'm going to do an emergency appendectomy." And, he explained to me what that was. And I said, sure, I'd love to go. So I stood there with him. I wasn't really much help, holding a retractor here and there. But that you could never do today because there's so many rules and regulations, having a 12-year-old in the operating room. But it was during those experiences that I just fell in love with medicine. So I was like laser beam focused, and like many pro golfers, and I had to use the example of somebody like Tiger. Tiger is laser beam focused, and that's where I was. medicine, because all I ever wanted to do was to become a doctor. So I studied hard. I got into a small liberal arts college and was at the top of my class. And then I went to Penn Medical School and realized that I wasn't the smartest kid in the class, that there were about 160 other really brilliant people. And I was just one of the smart kids in the middle. And as far as how I got into orthopedics, I always liked to fix things and tinker. And my father was the same way. And so it was sort of passed down. And I got into orthopedics, and then I always was intrigued by spine because of it wasn't sort of cut and dry. A lot of orthopedics was, you see a fracture, fix it. It's very gratifying, and I love taking care of the kids. But spine, there was a lot of decision making, because there's a lot of things we didn't know. And I thought, okay, this is a specialty that's, just starting out, and I can really become an expert in it. Well, lo and behold, it has exploded over the last 30 years.
Mm-hmm.
There was one journal, now we have a million journals, and there's a ton of people that are publishing research, and it's an exciting area. So, yeah, it was, I don't know if it was genetic or whatever, but I always wanted to be a doctor, and I always wanted to help people. In fact, I remember when I was in sixth grade, I did a term paper, and this is kind of bizarre. You'd never hear people talk about it before, but as to become a doctor, I remember writing a term paper on becoming a public health servant. That's what a doctor was considered to be back then, a public health servant. Well, you don't talk about that anymore.
Mm-mm.
But that's the way I felt. I felt that I was to serve people and to help people and to do good things. I didn't really have any interest in business or in law. I just wanted to take care of people and to help people. And even today, I have a lot of friends that have been in medicine for longer than me or less than me, and they have done something in business. And I don't have any interest. I just like people. I just like making people better. And for example, I just recently got an email from a patient who is very interesting, but he lives in Palau, and he sent me an email. He says, "Doc, I just want to tell you that this is the first time I've been pain-free in 23 years. He said, I know you probably hear from a lot of people. Well, not everybody will tell me that and send me notes, but that's what I live for. I live to make people better. And it's not the money. It's really just to help people and help them get their life back and help their quality of life. That's what turns me on.
Yeah, it seems to be that the people who rise to the top, and whether it's you in the medical field or pick anybody, let's use Elon Musk since he's in the news quite a bit lately, or pick anybody that's out there listening can just picture whoever you want to, and the sole focus is really not ever been on finances or money or achievement so much as recognition. It's always been to a simpler goal. You wanting to help people. I mean, that's very simple and easy to understand, and it seems to be the beacon that drives them, and that beacon doesn't ever go out, and it allows them to do great things beyond what everybody else seems to be doing, whether their goal might have been to reach a certain financial status or to reach a certain amount of achievements, plaques on the wall, recognition, etc. That the internal goal of something, as you just described, is that I want to help people. That doesn't seem like it ever ends, because there's always going to be somebody that needs some help.
Yeah, and Pete, I can honestly say that I haven't worked a day in my life. I mean, I go into work every day, and every day is a little bit different. Patients are different. I learn a lot from my patients about general life, about things that go on in the world, whether it's aviation or whether it's manufacturing. I had a patient that repaired elevators, and I wanted to know, well, how do you put the cables in? And he was
Mm-hmm.
telling me all the stuff. I mean, I learned so much from my patients, and it's not from the standpoint of helping them medically, but I like to learn about them, because I learn a lot about life. And what you realize, that people are people, and everybody wants the same thing. They want their health. They want to be healthy, to take care of their family. They want to enjoy their family. And, I consider myself to be a very, very lucky person to be in medicine, because, you can do things and you can do them all your life. Maybe, I would lose my surgical skills as I get older, but I can still see patients and I can still talk to them and I can still guide them and try to help them in other ways. So,
That's interesting. You bring that up, and I'm going to ask you a question. But before you answer it, I'll explain why. Do you think that getting to know your patients, let's say on a more personal level, what they do and how they do it, and so on, helps you in their care? And the reason I ask that is right now that there's on social media, in the golf world a little bit, there seems to be a discussion on whether uh, talent or hard work are better to have. And I was explaining that to my dad today. And my response to a lot of in the discussion was, well, you got to first of all define to me what talent means, because in my opinion, it's a physical predisposition to excel at something. For example, if you're 7 foot tall, you have a very good chance of being in NBA if you can walk and chew gum at the same time. Or if you have fast twitch muscle fibers, you have a better chance of being a sprinter than you do a marathoner. And my dad was a very good singer, and I was explaining it to him. Excuse me. And one thing he brought up was, in his opinion, Bing Crosby had a much better, not much better, but a better voice naturally than Frank Sinatra. He said the thing that made Frank Sinatra such a great singer was he lived and or experienced most of the things that he sang about, and that was a huge thing, at least so he says and thinks, as far as Sinatra's ability to make that song resonate with a lot of different people. So that's why I ask is, does the life experience and getting to know your patients and knowing what they do and what makes them tick and everything else help you in their care, in that maybe it leans you in a decision more one way than another way? Is that
you,
something that happens?
that's a great question, and you're absolutely 100% right. I will tell you that just anecdotally during the COVID, where we've done a lot of telemedicine, where I haven't had that personal touch with a patient, and there's something about touching a patient and connecting with the patient, and also getting to see them multiple times in the clinic, and talk to them, just about not just about their medical problem, but how they're doing, with life at home and how's work and all the rest. So it's sort of affected not all of my patients, but some of my patients that, maybe I have seen them several times on telemedicine, then they come in and they have their surgery. So I haven't developed the same relationship. Not that they don't do as well, because I still try to make an effort to find out about them, because that does help in what their expectations are going to be. For example, I'll say to a patient, so tell me what you want to do and what are your expectations after having surgery. In other words, if they tell me that they want to do X, Y, and Z, and I say, look, that's beyond anything that I or any other surgeon can do, and to certainly give you any type of procedure that's going to let you achieve that. But on the other hand, if they tell me that, look, here's my goals. I want to get back to playing, say, recreational golf. I want to be able to play with my kids. I want to be able to, to go to the amusement park with my kids, or I want to be able to stand for more than, 15 minutes without having to sit down. So these are really, really important things. Not only does it help with your relationship with the patient, but it also helps me, understand their expectations so that I can guide them post-operatively. Because I tell the fellows that we train at TBI, and we've trained fellows for God since the late 1980s, and these are doctors that are trained in orthopedic surgery and neurosurgery, and then they spend a year with us in just learning spine surgery by assisting in the cases, and they work with all the different docs in the group. So I tell them that half of the success of your surgery is number one, making the correct diagnosis, doing the right surgery, making sure that everything goes as perfectly as possible, and then the other half is supporting the patient psychologically, because a lot of times things are tougher, and I constantly tell my patients, recovery from surgery is 2 steps forward, 1 step backwards, and also you're there to encourage them because we have the experience of having seen the patients over a number of years and their response. So a lot of my time is sort of hand holding and encouraging patients. In other words, telling them that, hey, yes, this is a setback, but you're going to get over it. I'm going to help you get over it. Unlike what we have heard with some of the stuff about COVID, all this negative stuff, from that comes from, the politician, whatever. I mean, we have to be positive about things. And I'm a real firm believer and my philosophy of positive thinking, because I think positive thinking goes so far. And I am the person where the glass is half full,
Mm-hmm.
never half empty, because as in my job as a physician, I'm trying to make people feel good. And if they have a bad complication, which fortunately is rare, but if they have it, I'm there for them. I'm holding their hand and I'm encouraging them. I'm getting them through that. And I will make sure, and I tell them, all my patients, that if anything happens or if you have a setback, I will be there 100% and we will get you through this. But you got to listen to me, and usually things work out. But as a patient, you never know really what to expect. I've been there. I've done this for 30 years. So I know, what can go wrong. And I know when things do go wrong, what to do and how to get the patient through it. So knowing your patient is really, really important. And developing that relationship with the patient is really paramount. So it's not just, a patient you're doing an operation on. You're operating on a patient who has a family and, friends, and they have a job, and they have what regardless of what walk of life they're from. That's important because that's what you're trying to do. You're trying to get them to get back to their life, and that's the goal of the at least spine surgery that we do. We don't do life and death surgery, thank God. I could never have gone into a field like that. I like to make the patient's quality of life better. That's what makes me happy and makes them happy.
When you use the example of COVID, because you and I talked via teleconference the first time, and that and not having as much hands-on as you normally do, and not getting to know the person as well. It just seems to be that society is moving that way in general with all the social media, and I think it gives a false sense of people only post when they're happy on social media. So some people deem it as, well, I'm not happy all the time, so my job or my golf game or this or that or the other thing isn't as good as everybody else's. And I just, as you said earlier, if we just treated people like family, I think we also just got down to more human interaction as opposed to sitting behind a screen. There'd be a lot. We could solve the world's problems maybe on this podcast.
Pete, you're exactly right, because in social media, people will sit back and they will say anything because, they're not sitting in front of you. In other words, they would say things that they would never say to somebody's face because they feel emboldened.
Mm-hmm.
And that's not the way to treat people. I mean, words can be very, very painful, and, just the way they're worded and the capitalization. And I mean, I am appalled at some of the things I see on social media. I don't look at it too much. I really just look for happy things. But it's terrible. And this whole COVID, it's been bad even for the young kids,
Mm-hmm.
the little kids that, need that socialization to develop their personalities. I have felt really, really bad for them. But, getting back to my interaction with patients, there's something about touching a patient. And they've done studies that, when I do an examination, of course, I'm touching the patient, but I'm sort of the touchy-feely guy, and I'll put my arm around a patient. If they're upset, I'll put my arm around a patient and give them a hug when they're doing well. And I think that's really, really important. There's something about a human touching another human that is very comforting.
Mm-hmm.
And, it's a weird world. And telemedicine is great. For example, I wouldn't have met you, Pete, if we didn't have telemedicine. But there's also something to that personal interaction. And, for example, And I've done a lot of telemedicine over COVID. And some of the things are funny. I mean, in the beginning, God, people used to wear anything, and it's like, oh, excuse me, we're in telemedicine. Can you put something on?
I can see you, by
Grab
the
your
way.
underwear. I mean, it's really funny, and you see what's going on. One thing you learn about their family surrounding them. The dogs run around, the kids run around, and I remember one lady. She had 5 or 6 kids. I said, "Are all those your kids that are running back and forth?" She said, "Oh, I'm sorry," but it still is not the same as seeing the patient in person.
You are a rock star in your field, in your industry, and not only have you saved many people's quality of life, or given it back to them. Uh, the Texas Back Institute and yourself and your colleagues have saved the careers of many a pro athlete. Um, just so some of the people out there listening who might know your name, might know who you are, maybe read articles about you, but not quite what the Texas Back Institute is and the Research Foundation. Can you just touch on that a little bit and give them a little bit of background of what
Oh,
it is
sure.
that you all have and what you do?
Oh, well, listen, TBI was founded in 1982, and I was actually one of the original founding partners with Ralph Rashbaum and Steve Hochschuler. And we started with three of us with non-employees back then. And then we started the idea was that we wanted to form a spine institute. And everybody calls the name an institute, but I'm more of a purist. And if you look up institute, well, an institute is a higher uh, uh, higher level of learning or educational organization that also does research and trains people and this and that. So we formed the Research Foundation in 1986, and we started doing basic research. And when I was finished training, I didn't want to just be in private practice. I wanted to be able to give back to our specialty by doing research, whether it was clinical research, which was what we had access to. We didn't have really access to basic science research with animals and things like that. So we started basic clinical research, and we did a lot of very basic things or basic clinical studies, for example, and various diagnostic techniques. We were one of the first to work with CT scanning, then MRI scanning and lumbar discography. And we brought in other docs in our group, and we pioneered thoracoscopic surgery, and we were one of the first to popularize anterior lumbar surgery. We also participated in many FDA studies with bone stimulation and bone growth through electrical stimulation. And then we got into artificial disc, and that has really been my major focus. And that started really in 2000. We did our first artificial disc study, and we did the first lumbar artificial disc in 2000. And since that time, we participated in about 15 lumbar, which is the low back, and cervical, which are the neck artificial disc studies. And I'm proud of that. And we have been the lead, what we call principal investigator, which that means you're responsible for the study of all the doctors all over the country that are doing the study. And you actually have to act as the arbiter. In other words, if somebody tries to get somebody in a study that's not appropriate, then you have to talk to them, say, hey, John, this patient's not appropriate. And me personally, I've been the PI of many cervical disc studies as well as lumbar disc studies. And recently, we just published this is the ninth cervical artificial disc that became approved by the FDA. And I was the co-PI with another doctor. And we published that, just published our 2-year follow-up. And I gave a paper at the Cervical Spine Research Society that won the third Basic Science Award, the third place Basic Science Award. So our research foundation has not only published in this area, but also in robotics. We have other surgeons that have pioneered robotic surgery. We have also pioneered many new implants and studied them as well. So right now we have 20 surgeons. We have about a half a dozen of us that are very active in publishing clinical research. And before COVID, I used to travel all over the world. And I say last year I traveled all over the world, but I went nowhere. I sat at my desk. I went to Singapore, Beijing, Australia, Um,
All
you
from the
know,
comfort of home.
all from the comfort of home. In fact, last Saturday night, because in Beijing they're 12 hours ahead, I was giving a talk to the Lumbar Spine Research Society, or the Chinese Lumbar Spine Research Society. And of course, they were all doing it from Zoom as well. They were all sitting home. So we had made a name in research, and that's really put TBI on the map. Several of us have been presidents of various spine society. I was the president of North American Spine Society, which is one of the largest spine societies in the U.S. And then we have several other members that were president of it used to be called the ISAS, the International Society for Arthroplasty Research, and now they renamed it, so now they're called the International Society. And then another one of my partners is president of the International Lumbar Spine Research Society. So academia has been very, very strong, and that's why we also have a fellowship. I started the fellowship back in 1986, and we trained over 135 surgeons that are practicing all over the U.S. and also all over the world. We train actually a number of Chinese spine surgeons, and as well as in South America and Europe as well. So that's also been a part of my life. It's an important part of my career because I love teaching. I love lecturing. I still do a lot of hands-on teaching courses for the cervical and lumbar artificial disc as well. So, but it's just not me. And I don't mean to highlight that I'm the only one. We have, many, many prominent surgeons in our group that have made significant contributions to spine, and we're proud of it. And in fact, we publish as much as many of the universities, but yet we supported the research ourselves. And just anecdotally, I will tell you that when we first started our research center, we, as a group, we kicked in $200,000 a year for 10 years. That was $2 million we poured into research out of our own money. These weren't NIH grants, out of our own money. Now, spread among the number of surgeons, it still was not nothing. It was, $20,000 to $30,000 per surgeon, but that was a lot of money.
Mm-hmm.
That was a lot of money. And we still support internal research. We still have, research grants, but, we started out because we felt that, number one, we wanted to make a difference. We wanted to commit, or to further spine science. And, when we started out, those of us that were in the core group, we like to lecture and travel, and it's been fun. I mean, I've traveled and been guest speaker at 5 continents, and I've met a zillion foreign friends all over. And what it's taught me is that, and I said this earlier, but I mean this in a broad sense, that people are the same. I don't care what color you are, what race you are, what country you come from. We are all the same internally. We all want the same things. We want to provide for our families. We want our families to be happy. We want our children to be happy. And if more people understood that, I think there'd be less, strife in this world. And a lot of the craziness. But unfortunately, social media and 24-hour news has made us crazy. And those are the two things that I think have ruined our society.
No doubt about that. Too bad you can't do a surgery on that.
No, you can't do a surgery on that. I wish we could. But unfortunately, and listen, I think that Steve Jobs was brilliant with the iPhone, but he said he wanted it to be the first thing you picked up in the morning and the last thing you put down at night. And unfortunately, we're all addicted to him now. And then you look at Ted Turner with 24-hour news with CNN. That was a great thing. It was wonderful. But now I'm telling you, the two of those are the plague of our society. And, I live by my phone. That's how I communicate. That's how people can get by me. And it's unfortunate, but that's where we are today. It's sad. But anyway.
As I was reading up more on your facility and one of the things that kind of jumped out at me as I was reading I was reading over and over was the disc replacement seems to focus on cervical. For some of you listening, that's your neck, and your lumbar, which is your low back. I didn't see anything that dealt with the thoracic or the mid back. Are there reasons for that, or is it just not as common?
Well, first of all, you have the rib cage that supports the thoracic spine.
Mm-hmm.
There's not a lot of motion in the thoracic spine, and the main reason is that it would be very, very hard to do an artificial disc because you'd have to either go through the chest or you'd have to remove parts of the rib in order to get it in. And there's for some reason, I think it's because of the stability of the rib cage. It's just not that common that patients have really debilitating thoracic pain. If they have tumors, that's another reason. If they have, fractures, then of course we operate on them. But fortunately, it's not a mobile part of the spine, unlike the cervical and the lumbar spine, and it has the benefit of having a supporting rib cage.
Do you find as the cervical and the lumbar mirror one another that one area can or does cause irritation or issue in the other areas? For example, if somebody has a neck issue, that it will eventually work itself into the lumbar as well?
Well, it doesn't necessarily work itself into the one area or the other, but I think it's probably genetic predisposition. I would say, and this is just an empiric number, but of the number of patients that I've done lumbar disc, about 15% have cervical disc replacement or cervical problems, and vice versa. The cervical people I operate on, I've done, a significant number of lumbar operations on them. So it's not uncommon that, they'll have one area. And, like I just had a gal that, I operated on her neck, I don't know, 5, 10 years ago. And last year we did a lumbar disc replacement. Now, that's not an isolated thing, but it's fairly common that, if you have the genetic predisposition to, develop degenerative disc, then you may have both areas. But also have had patients that have perfectly normal necks and they only have a problem with the low back and vice versa. So a lot of it is genetics, and they are slowly unraveling you know, the gene sequences that are involved, and they're getting close in the lumbar spine. The cervical spine, I haven't read anything recently, but we haven't come to the point where you can send your cells out, or your mouth swabbing to
Mm-hmm.
one of the genealogy places and say, oh, you're going to have predisposition to lumbar disease or cervical.
Mm. So as I was reading up, the disc replacement, if I'm going to butcher this, probably the name of it, is it Charite?
Charite. It was the very first lumbar.
Okay. And you were the pioneer, what I get, of bringing that from Europe to the U.S. You went over to Europe to learn more about that and understand it.
Here's the real story, Pete. So we had a fellow that we trained, and he was joining our group, but he wanted to spend time at a children's hospital, Scottish Rite, which is in town. So I said, okay, you can do that. And then he said, well, what am I going to do for the next 6 months? Because our fellowship really starts at the academic year, which is August 1st to July 31st. Same thing as residency.
Mm-hmm.
Or actually not. Residency starts on July 1st, but we push it back because the docs had to train for the board. So he said, but what am I going to do for the next 5 months? I said, you can do whatever you want. I can get you set up to go to some other centers. And then we had learned about the Charité disc from Karen Buettner-John. It was called the SB Charité. She was a resident in Germany, from East Germany, in fact, and she was also an Olympian. She won 7 gold medals, silver medals, and whatever, and in gymnastics. And she was a fantastic gal. So we brought her over in 1990 to give a talk, and she had a book in Germany, in German, that we helped translate through our research foundation. And we were intrigued by that. So, and it made sense. And this was early in my career. I said, why are we fusing people? Why aren't we doing artificial disc? And, and there's been some really crude attempt, but hers was the first modern one. So to make a long story short, the company had to do more biomechanical testing. Well, we helped them do it, but we sent over this young fellow, and he's the one that sort of scoped her out, because we said, go over there, learn about the artificial disc, and come back. So that was in 1990. So we, we helped them do the biomechanical studies. And then finally the FDA said, okay, you can start your study. And we started the study in the year 2000. So that was the very first artificial disc. It wasn't very good, but it was pretty good. I still see patients that we did way back when that are doing fine. They're not wearing out. They've not been revised. And in fact, our revision rate is very, very low because we knew how to put them right, put them in correctly. When I say we, my partners and I,
Mm-hmm.
and so did a lot of other docs. But it was a very unforgiving disc. It was very, very finicky. If you didn't put it in exactly right and get the angles right, you weren't going to have a good result. So it stayed on the market till about 2012, and then it was taken off the market. And then at that time, we had the Pro Disc that was actually approved a couple years after the Charité. But that's been a real workhorse. That has been great. It was well designed. And then now we have the Active L. So we only really have 2 lumbars. We have 9 cervicals. So it shows you where the market is.
Mm-hmm. Is somebody who had been a surgeon and you were doing back surgery and fusions and things like that before, was this something that was rolling around in your mind on well, if that maybe you were trying to come up with something like this and then that this just happened to evolve?
Well,
Or did you learn about that?
No, it's funny that you said it, Pete. And what bothered me is that we would see patients come back after fusions, and then the next level would go bad. And we had actually done a very basic, or I had done a very basic biomechanical research where we tested the pressure. It was a very crude test, but by today's standards of all the sophisticated stuff we have, and what we found is that and I knew this had to be the case, that the pressure was increased at the level above a simulated cadaver fusion. And that paper was published. It still gets quoted today, but it was one of the very first papers that sort of brought out the point that maybe these fusions are aggravating the next level up. So in my own mind, because when I finished training, total hips and total knees, they were the commonplace thing. Nobody ever did fusions. I mean, you would never have the patient come in your office and say, well, you have a bad hip, I think we should do a fusion.
Mm-hmm.
No, they came in, you did an art. So it didn't make sense to me. And I knew that there were some very rudimentary ones that they tried. So my partners and we developed a fusion device with the idea that the way it was designed, the next step was to make an artificial disc. So unfortunately, that company got bought out, and the idea, although that fusion device is still used, it was modular in that you could replace the center with what we had designed as an artificial disc, but it never got that far. Well, so it's not that, I learned about it from Europe. It's just we had been thinking about it. We just, we didn't have the luck of having the company stay around and saying, hey, here's the design. But that was always in the back of my mind to, make an artificial disc.
I figured it had to be. That's where that question came up. And nobody that I talked to prior to the interview had given me any of that information. Just in the brief time that I've known you, and reading about you, I'm like, I would have to assume that Doc Geyer had to have this in his mind somewhere where he was thinking about this before it was developed over in Europe.
Yeah. And Pete, think about it. It doesn't make sense. And here's the problem with the lumbar disc. It is a wonderful operation. You do it right in the right patients, and you will get, when I say you, the surgeon will get a lot of letters like I got from this patient I told you about that. And I haven't felt this good in 23 years. I mean, it's amazing. And I had another gal that I did 3 levels on, and she writes to me, or I did a telemedicine. She said, Dr. Geyer, I have 0 pain. And I said to her, Donna, how long had you been having pain before we did your surgery? She said, 20 years. Mm. So the point is, and I'm not tooting my horn saying, oh, my great surgeon, all my patients like, they're not all like that, believe me. But if you choose the patients well, the lumbar disc replacement is a wonderful operation. The problem is, number one, the insurance reimbursement stinks. We as surgeons get paid about 1/5 to 1/10, depending on the kind of fusion you do. It's crazy. It's crazy. I do it because, number one, I've been in practice a long time. I love what I do. I love how it makes the patients feel. And I love the fact that I'm not doing something that's going to encourage another operation to be done. So that's part of the problem. And the other part of the problem, we have to do it through an anterior approach, and you need a what we call an access surgeon, general surgeon, to get us to the front of the spine because the blood vessels sit on the front of the spine. And it is a very safe operation. It used to be said, oh my God, it's a horrible operation. You're going to kill somebody if they have to revise it. Our revision rate is only a couple percent. And this is since 2000. In March of 2022, it'll be 22 years. So, and the other problem with having the access surgeon is that you have to split part of the fee. So not only do they pay you 1/5 to 1/10 of a fusion, but then you have to split part of it with the access surgeon. But it's a technology that if you really want to help people and you really want to look at the future, what their spine is going to be, this is the operation to do if they're the right candidate. I'm not saying everybody's a candidate. Not everybody's a candidate, but you have to, be very, very selective in those patients that you choose for the operation.
And for those who don't know, anteriorly means you go in through the
Yeah,
front,
we go in through
through
the front.
the stomach area or the
Right.
low pelvis area.
We make an incision in the front and we go in between the six-pack muscles called the rectus, and the access surgeon slides her hand or his or her hand along the inside of the abdominal wall, and they pull the sac back. So we don't go through the stomach, and that's why most patients go home in less than 24 hours. And a lot of my colleagues do them as outpatients. We keep them overnight, but they still go home the next day.
That's
So
amazing.
we still call it 23 and a half hour.
I remember when I was a kid, my mom had back surgery. I think she had one of her vertebrae had there was a bone chip in there. It had broken off at some point, and I don't know what part. She had, now this would have been about 1980, and she had back surgery. She was in the hospital about 6 weeks, and now you're telling me that some of your colleagues are sending them home same day or
Yeah.
next day on a major. I
Oh,
mean, you're replacing a disc. This isn't like you're going in for.
hey, I will do 3 levels. I will do what we call a hybrid, 1 or 2 level fusion or a 1 or 2 level fusion, a disc above, or a 1 level fusion and 2 levels above. And we'll still send them home the following day. 70% of the patients go home the day after surgery. And even if we do a fusion called a 360, which is from the front and the back, because we use minimally invasive techniques, they still go home the following day. And those same patients used to stay in the hospital 2 weeks. We used to do the front part, wait a week, they stay in the hospital, then we do the back part. And because this was all open, and they stay in the hospital 2 weeks. We'd have them stand up the first day, they take a step. The second day, they take 2 steps. The third day, they take 3 steps and might walk in the hallway the fourth day. We get them up walking, and it's truly amazing. They're driving a car a week.
That's mind blowing. That how not we are talking about sometimes bad technologies. In some respects, technology is a great thing because minimally invasive surgery,
Oh,
regardless of the
it
type you have, it is absolutely unbelievable.
it has changed spine surgery. It has actually changed spine surgery. I
It,
mean, and I tell my fellows, I say, you know, I wish I was 20 years younger because there are going to be so many more advancements in spine, when they're my age in their career. It's going to be robotics. It's going to be, robotics with navigation. It's going to be so much better for our patients. I mean, the surgeon's still going to be very, very important in planning the surgery and programming, working with the program. It really, if you look back, there was robotic prostatectomies
mm-hmm.
and, robotic GYN surgery. And then slowly has come over into where we are today. So it's just amazing. I mean, the MIS is the wave of the future. And, I always hear the complaint from some of my colleagues. They say, well, they need to know how to do it open. Well, yes, they need to know the anatomy, but you know what? The technology is such that, and the imaging is such that even if there's a breakdown in the system, there'll still be workarounds. We'll still be able to get those surgeons through it. I mean, when I think back how I was trained, oh my God. I mean, even total hip surgery, we used to do them through big slashes. Now they do them through little incision. They send them home the same day.
Mm-hmm.
And we used to keep them, again, a week.
One thing that strikes me is interesting is getting the disc the right size, because not long ago, I had they had to take out an old filling that I guess had mercury or something, and they said it's time. You've had it for 20 plus years. It's time you do what's the material they put in there? Porcelain. I said,
Right.
okay, fine. And just the smallest amount, millimeter maybe, of being off caused me to have jaw and headaches for a few days until they could get the filing down and the fine tuning of it right. And as I'm reading about some of these things since we scheduled this and tonight, and it's like I'm thinking to myself, okay, you're putting a disc in somebody's back, which if it's off by a millimeter can cause a lot of problems. So how do you go about ensuring that the disc itself is the correct size and then the placement is correct so that the person doesn't leave and then they say, well, hey, I'm in as much pain or more than I was when I came here. You don't know what you're doing.
All right. So again, Pete, it takes experience
Mm-hmm.
and having done hundreds, if not thousands. And and I teach my fellows, I say that you have to take that extra 5 or 10 minutes in the OR, and they watch what I do. I say, because if you cannot make this perfect, it may or may not affect. Now, sometimes you try your best and it may be a couple millimeters off. And we do have leeway of a couple millimeters. But you try to do your best. And we have templates at surgery so that we can measure the height, the angle, and also the size of the footprint. They work for most people. Honestly, I think that in the future, we'll have some ability to 3D print the end plates so they fit exactly and they're the exact size of what we need, because there are some petite women, and even the smallest disc may be too big. It might be a little bit too high. Fortunately, the lumbar spine is very, very forgiving. The cervical spine, we have a lot more options, so it's less of an issue. But you need to make it as precise as possible, because you want to give that patient the best chance of, the symmetric balance of where you place it. Understanding that you do have a couple millimeters leeway, but I'll tell you a little joke in the OR. So, you talk about a millimeter. Well, in the OR, my X-ray tech, and now everybody talks about it, and we'll look at the X-rays, and I'm a real nitpick, so I'll change things until they're perfect. And he'll say, it looks like it's only a guy off. Are you okay with that? And so, one of the fellows says, well, what's a guy? So the X-ray tech, well, it's like a sub-millimeter. In fact, it hasn't been defined, but it's really, really tiny. But that's the point. In other words, you want to make it look perfect, and because that's going to hopefully last the patient for a long, long time. And the patient's also going to see the X-ray when they come back. And I always take pictures and I send them to the patients, or let them take pictures off of my phone, because that's what they're going to live with forever.
His hips and knees seem to be lasting longer and longer? I think I could be wrong on this. You would obviously know where they were
Well,
maybe 10 to 15 and now they're 15 to 20. Are
yeah.
disc
So
lifetime, or there's
because
a time frame?
I don't know how long they're tested. They're lasting now, Pete. I do know in the beginning it was 10 years. Then they say, they have to do a revision. So when we started doing our artificial disc in 2000, we told the patient, judging by total hips, are going to last 10 years. So that's 10 years of motion better. It's better to have 10 years of motion than to have a fusion and then 10 years of stress on the level above. Well, lo and behold, we're starting to see, we don't have a lot of patients that are 22 years, but, we have some that are 19, 20, 21, 22. We have a lot that are 17 and 18. We are not seeing any significant wear. And the difference is, and I was just telling some pre-op patients today, is that, if you walk 10,000 steps a day, that's 10,000, ranges or cycles on your hips and your knees.
Mm-hmm.
Whereas, you're not bending forward, touching your toes and leaning backwards 10,000 times. Even though they're tested to last 40 years, I'm inclined to believe that they won't wear out. We're not seeing wear out anytime soon. We're seeing now that we have 20-year plus follow-up, and we're not seeing significant wear. Even some of my early Charités, I don't see significant wear. So that's the good news about the cervical and lumbar disc replacements.
That's awesome. You don't have to go in for your oil change, maybe but once in your lifetime.
No, that's that. But changing out total hips, and I'm not up on the latest, and you might be right, Pete. Maybe they're lasting 15 or 20. I don't know. But back when I was in training, it was about 10 years. They were telling patients, "Oh, you're going to, a chance revision." We go in there, change it out. Well, you can't go in and change a lumbar out. You can change a cervical. We can exchange one cervical disc for another, just because the approach is very easy for us because we do it all the time. Whereas in the lumbar spine, once the vessel scar at the front of the spine, you really don't want to go back there unless there's something like an infection or
Mm-hmm.
displacement. And knock on wood, if it's put in properly the first time, you're not going to see that.
Good. We've obviously established, for those who didn't know you coming in, that you obviously are exceptional at what you do. If I can, I'd like to ask you a little bit about golf in the spine.
Sure,
Since
absolutely.
you have worked with golfers and athletes of all types. Do you think that golfers seem to have more back issues, or is it the population in general that has back issues and golf seems to be a multiplier of that?
Well, I think it's probably a combination. Golf puts tremendous torque on the spine. There
Mm-hmm.
is no question about it. In fact, we just published a paper, and it was something to the effect that,
Is that the one you did with, was it with Dan, and
yeah,
there
yeah,
was one
Dan,
other person? I can't
absolutely.
remember who the other one was.
And yeah, so we just published it, saying that it is really very, very stressful on the spine. And you know just to pat us on the back, we published in the Global Spinal Journal and Spine Journal, and that was the number one read and requested for reprint of any article published last year.
Wow.
How do you like that? That's the first time I had that. In fact, this is funny because when I gave my talk in Beijing, one of my very good friends, who's chairman at Peking University, it was or Capital Medical University, he is chairman of the orthopedic department. He published a LinkedIn thing, and his was the number third read. Well, he's one of the co-editors for the journal, and he wrote me. He said, "Rick, ours was number 3, but guess whose was number 1?" I said, "I know, Jan." So when he published his in LinkedIn, I put a little note. I said, "Congratulations, but who had the number 1 paper?"
You got to rub it in a little bit.
So anyway, getting back to golf, and I really think that Tiger is the one that started this all, because he started really stressing the workout. And now you see all the young golfers, they are, they're buff guys and they work out all the time, and their swings are so violent. I love watching women golfers because they take that nice, easy swing. And I can't remember the last time I saw a college golfer that had a back problem, a female. But I would say it's like 20-1, male golfers that I see to the female golfers, or maybe it's 50-1. I rarely see a female golfer with a back problem. And I think it is the mechanics of the spine, and plus some genetic predisposition.
Do you think, men obviously have, I think last I read, the 30% more strength or muscle mass in women, but women are much more flexible. Do you think those two things in combination have anything to do with that?
Yes, I do think it. And I think that women are, they're not trying to kill the ball like,
Mm-hmm.
the male golfers are. They're trying to get the long drives. And so I think that a combination, number one, their flexibility. And secondly, I think their mechanics are, to me, they look smoother than the male golfers. I mean, I love watching the female pros.
Dan Hellman, our mutual friend, we had that discussion last time he was on the show, that his concern was that with the chase for distance in the men's game in particular right now, and that plus the speeds that they're swinging at and the amount of torque and forces it's sending through the spine, that he was very concerned about that going forward.
Oh, listen, I'm so concerned about it. I mean, I think that's the reason why, you know, and you don't see this much, but at the end of the first 9, they're all popping their Advil. I
Mm-hmm.
mean, and because their back's hurting, they're aching, and not all of them have bad enough problem that they end up having surgery, fortunately. But they're putting a lot of stress on their spine, much more than I think some of the heavy laborers that we see.
There's a massive array in is golf and the body and everything has been so for good and bad, as we've discussed already, as far as advancement of everything in the world today seems to be at such an accelerated rate, and probably in large part due to the internet, where ideas can be shared and discussed for bad, but there is also a good side to that. And where I'm going with this is with all the different training and therapies, like the L-DOA being one, and stretching and yoga. As far as protecting the back, does making it stronger, there appears to be some debate from what I read and watch and listen to about how to strengthen the back and the big one that seems to be brought up is deadlifting. It's being promoted as well. It can increase your reaction with the ground and how your feet interact, and it can improve swing speeds, and you get stronger, your back's protected. Where other side of that argument would be, yeah, but why are you extending your pelvis and your lumbar spine as many do in the deadlift? Because that's really it happens in the golf swing, but it happens towards the end. Do you have an opinion on the strength training, and in particular the Olympic style lifting, deadlifts or things like that?
Yeah, the deadlifts, I see more patients, not necessarily golfers, but patients in general, that hurt their backs with deadlifting because they're trying to go for higher and higher ridiculous weights. And in 1 week, I think in a 2 week span, I saw 2 or 3 patients, male patients, that hurt their backs with deadlifting. And, I don't, there's other ways you can strengthen the spine. And, there's a way of shifting, the forces away from the lower lumbar spine. And Dan is really, an expert in that area in trying to help them lessen the stresses on the lower spine. So, I understand that, and I understand how they get into this and try to do more and more weights, but there's other ways to do it. I personally am not a big fan of the deadlifts.
Yeah, I had Dr. Craig Boatwright is a local orthopedic. He's the head of orthopedic surgery here in Hilton Head, and he was on the show. He's a friend of mine, and we talked about squats, and he said, look, if you're going to do body squats or maybe some goblet squats where you're holding a dumbbell in front of your chest, it's probably the benefit is probably outweighs the detriment. But you start putting bars on your back and load that's compressing, he said, you're looking for problems. In his opinion, and I would tend to agree with him, and you correct me if I'm wrong, it cannot seem to be a very good idea to add more compression to your spine.
No. I mean, first of all, golfers get, a lot of golfers will get what we call facet syndrome, from the torque and the twisting. So they bang up their facets. The facets, remember, are guides. They stop our spine from twisting around 360 degrees. I mean, I'm exaggerating, but basically they allow a certain amount of rotation. Okay. And that's how, the golfer can, swing and twist his trunk. But when you do that deadlift with the bar in your back and you're squatting down, what you're doing, you're compressing the heck out of your facet joints and also your disc. I mean, so I am not a fan of that. I really discourage my patients from doing the deadlifts, but I'm certain people, they got to do them, and okay. And if they get away with it and they have the good genes and good physiology, they can do okay.
I have a fair amount of people ask me. I have a number of students, and I have the show, and I've been in our area a long time, and it's not a big area, so I guess I'm just relatively well known for being in the golf industry as long as I have.
You're a rock star.
Yeah, in my own very, very small fishbowl. I'm not even in a pond. But I get asked about the same topics, and Bryson comes up in particular because he seems to be changing the way that people are viewing distance. And the scientific data, so to speak, on the measurements say, and this part is nothing new, that if you hit the ball longer, then your probability of scoring lower is improved. That to me is nothing new. To some people it is. But I sit there and look at Bryson and I say, okay, you can bulk up and you can protect your body as much as you can with weights, but the torsional forces going through his body at some point, swinging that hard that often, is going to have an adverse effect. I hope it doesn't. I mean, I think he's very good for golf, but I just don't see that lasting.
Um, you know what? If you go back and look in the old time days, with the golfers, the pro golfers, I mean, they were heavy folks. They were not slim and trim,
Mm-hmm.
and they played really good golf. And it's my philosophy in life and in everything is the keyword moderation. I once read a book. It was called Equanimous, and basically it was never get too high in life and never get too low, and more of a psychological thing. But I also use that for the rehab and things like that. In other words, you don't have to go crazy. You don't have to do the most of anything. You shouldn't do the least either. You need to find a happy medium. And what happens is I think that some people are going too far.
Yes, and they're finding out what I mean. I've had a fair amount of experts on my show, and what the masses, either in the industry who are working in it. In my industry, it's the coaches or instructors, or at yours, it could be other orthopedic surgeons. What the masses are hearing and implementing is much different. I'm finding out than what the people who are at the cutting edge of that technology are either saying and or doing. Um, and I give an example is in the golf side that a lot of the measuring devices, which are phenomenal things to use, to relate it to your industry, like an MRI machine or so I'm not as up to par on the latest technology in your industry, but I know MRIs are very good. CAT scans. These
Right.
things can tell you what to do, as they can in the golf with things like TrackMan, Flight Scope. Hack Motion is a wrist measuring device, measures the angles of the wrist and how it's working throughout the swing. Force plates, all these different things are great, but the masses seem to be wanting to use these things for like every swing or every other swing during a lesson, when the experts are using them to check to see if the solution that they implemented with the student is working the way that they hoped it would. In other words, it uses a checkpoint or as a measuring device and not as a continual uh, device to enhance teaching, but it eventually becomes a crutch. So I
Right.
think the message from people in your position or people in like Dan's position in the therapy world, or like Scott Calks in the golf world, is very big in doing testing on the Hack Motion, the wrist device. But was dribbling down in the message that a lot of the masses are hearing is not what you guys are saying. So somewhere that's being lost, and I think, but the masses are reaching more people, right? So
Right.
so that their influence can and oftentimes, unfortunately, can be greater on a large amount of people than someone like yourself, which is unfortunate. If we could clone you, the back world would be a lot better position.
I know.
Um,
It's
you had
that.
mentioned the spine and how it worked in the swing and the twisting and the torquing. I wanted to ask you because I was reading up on one theory that is out there in the in the golf coaching world, and it didn't, as far as I could gather, it did not start in the golf arena. It started, I think it was in running, and that has to deal with the spinal engine. And Sergey Gradovetsky, I believe was his name. Are you familiar with
Gravetsky.
that at
Yeah.
all?
Yeah. Uh-huh. Uh-huh.
What is your opinion on that theory as it relates to golf, or
Uh,
the swing and the spine in particular?
well, I mean, in Pete, be more specific. Are you talking about the spinal engine? I
Yes,
mean,
the spinal
that
engine, where the theory in golf is if you twist it and then you have a bend to it, which would for a right hander would be right lateral bend, and then you have the torsional movement of the spine that as that aids in allowing the pelvis to open up, and then the spine will snap back, and that becomes the engine. So the spine is the equivalent of the engine of the movement. It's not the pelvis and the legs.
well, you know, I think it's really a combination. I don't think you can say it's entirely one or the other. I mean, this was an old theory about the spinal engine.
Mm-hmm.
Um, you know, I think what happens is that um, it's almost like people are starting to overthink things, and it
It's made it
it's
much
sort
more
of like
complicated.
Right. We're trying to make things so complicated, and it's almost like, you learn your basics, and then you get out there and you let, sort of your instinct take over. And, just like a natural athlete, in all sports, whether it's golf or, football or basketball, you have certain instincts and they know what to do. And it's almost like, I'm trying to give you an example, like in my area. Uh, Sometimes, I have surgeons that, and we discuss cases, they try to overthink it. And if you just sort of go by the basic principles and not get so complicated, um, you're better off, you know, just staying to basics. I guess I can't really put it into words, but I think what we're trying to do is make things so complicated and putting names on things and, trying to make sure the angles are right and, the pelvis opening up and are we, getting the proper recoil.
Hmm.
All you have to do is look at a golfer and, at least a modern day pro, and you watch them swing, that they are putting tremendous force on a spine that really was not made for that force. Okay. So, the golfer is as much as a contact athlete as, a football player, a hockey player, rugby player. They put just as much stress on their spine as those players put on the remainder of their body as well as their spine. So,
Is most of the issue for the golfers in that it starts around the L1 area, and then it ends up being an issue lower down in
no,
lumbar,
I think
sacral?
it comes, this is where you can get into the chicken or the egg. Is it the pelvis or the spine engine? But it usually comes from the lower levels because that's where most of the twisting is coming from. In the upper levels, you still have motion, but you have a little bit of the protective effect as you have the transition from the thoracic spine to the upper lumbar. So whereas the lower lumbar, for some reason, that's the one that takes the most stress. That's the one that has the most motion. For example, the lumbar lordosis. Well, 50% of the lumbar lordosis comes from the lower two levels. When you have the lordosis, which is the angulation of the lumbar
Hmm.
spine,
Is
so
too much
that's
curve
the
in the
one that
lower
gives
back, right?
the curve on the side. Okay, so 50% comes from L4-5 and L5-S1. That allows us to have the flexion. In other words, if you flex forward with your trying to get your hands to the floor, when you first flex, most of it comes from your hip with your hands to your knee level. The remainder of the flexion comes from when you go from your fingertips from the knee to the floor. That comes from your lower lumbar spine and a little less from the upper lumbar levels. And that's why I think that those levels are more susceptible. And we see this in our patient population. Most patients are going to degenerate L5-S1, L4-5, sometimes L3-4. Really do see the upper levels degenerating first. It's always the lower lumbar levels.
Is there a reason for that in being a sedentary society, or is it genetic,
No,
or is it?
no, I think it's a combination of your genes and also with what we do. Look, we have a lot of, whether it's you're a recreational athlete or you are an industrial athlete with, you might be a guy that's, a road repair guy or doing construction or building homes. Those are also physically very, very hard on the back. You're bending, the lifting, the twisting, um, and then the genes. So, it's a combination of your environment as well as what mom and dad, passed on to you genetically.
Mm-hmm. As I look at uh, the evolution would be an incorrect term, but I'll use it anyway. The evolution of the golf swing, in that if you look at, let's say, the Jones era, and you watch golf, I know. I don't know how much you play or if you play much at all, but you're very
I
attuned.
used to
Since
play until I developed a bad back. I'm
okay.
serious.
And you have it, well, you couldn't do the surgery on yourself, I wouldn't assume. I mean,
No, no, no. And unfortunately, I have a little scoliosis, a few degenerative discs. They wanted to do multiple level fusion. I said, no, no, I'm just going to do my core exercises and everything else. So I do fine. I can do my surgery. I can do the things I like to do. Some things I had to give up. Um, but anyway.
But it is the swings have changed over time, and if you look, I classify it really as pre 1980. So let's say Bobby Jones up to the early Nicholas era, where you had uh, a flexion of the spine, the pelvis, and you had more rotation. You had free moving parts, and it was make a big turn and go ahead and play golf. And then you get into the early 80s and the whole era up until recently, I would say. And I'm sure there's going to be some golf coaches out there going to argue with me on dates and everything else, which is fine. I'm trying to paint a generic picture here for the average everyday person listening. So let's say from the 80s until a few years ago, where there was the restricted movement. So what they wanted to keep part of your body restricted and rotate hard against it, and then the idea was it would snap like a rubber band, and you could improve your ball contact that way. What I'm seeing modern, meaning the last 5 years to the masses, maybe 10 years going back as it developed, is there is, and I think this is has more to do with the inclusion of the medical industry, physical therapists, trainers, and those people getting in touch with someone like you, is that there is, at least what I'm seeing is with a lot of the better coaches, there is as much focus on the body, how it's supposed to work, and what's good for it as there is on ball striking. And with the reason I bring that up is with the number of people that you come into contact with that are either coaches or trainers or what have you, are you seeing any difference in the ability for the golfer to preserve their backs, or is this theory of mine just completely BS and I'm barking up the wrong tree?
No, I think you're right, Pete. It's sort of a compromise. Again, you take the middle of the road approach. In other words, like you said, before you wanted to keep, you know, part of your body fixed and then snap back. Well, just the word snap back is like the human body wasn't made to snap back. It's
Mm-hmm.
made to move. So, I think that you're going to see a trend for a more smooth um, swing. I think that right now we're sort of in this era where it's a powerful swing. You want to hit the ball as hard as you can. Like you said, you talked about Bryson, but you know, I think that we're going to have to step back because you know, and I don't know the prevalence. I've never seen. Um, some recent data, although we have some older data about the prevalence of back pain in golfers, but it'd be interesting to do a survey of the older golfers compared to the newer golfers, with the more modern swing. But I think you're right. I think it's going to slowly come back to the middle. I think that, probably where it was, as you said, the, pre 80s and where it is now, there's probably a happy medium somewhere in between.
I hope so. Especially as people, golf has always been promoted as a game for a lifetime. You can play with your kids, you can play with your grandkids. You can get outside and enjoy camaraderie and weather and time away from stressful situations. Although golf does create a lot of stress for a lot of people, and being in a retirement area, I see it all the time where people think that they're going to retire and play golf 4 to 5 days a week, and they're going to go from a 15 handicap down to scratch, and they realize that playing every day can frustrate them, and their handicap can go the other way as well. There's more
Yeah,
parts of the game than just hitting balls.
it's funny you say that. I just saw a patient back, and he's a year out from a surgery. He had a fusion. He couldn't have an artificial disc, and he recently lost his wife. So he said, "I'm playing a lot of golf." He says, "Doc, but I got my handicap down to 8, and I play with my grandson, who's I think he said he was 11." Because we were talking about Charlie Wood, and so anyway, his little grandson is really good, and he brings him out to the golf course with his buddies. And his buddy said to him, he says, "Why are you bringing this kid out?" So he shot par from the women's tee,
Wow.
and so all his buddies are saying, "Oh my God, you can come out anytime, anytime." I mean, it's a real superstar, reminding me of little Charlie Woods. But anyway,
That's pretty cool.
so yeah, it is a great sport, and he obviously he's been playing all his life, and it is a wonderful sport, and you'd like to be able to preserve it so that these scoffers can play, as you say, as long as they want to play. But they do put so many reps, they hit so many balls, and it's like you have so many miles left in your tires, and eventually going to wear things out, unless you just have this genetics that lets you, you know, do whatever you want. And there's some people like that. I see some people in their 80s that have backs that look like they're, in their 40s. Now they're rare,
Hmm.
but if you're lucky enough, then you can do it.
I think that's coming around now to be more common in that, and I'd have to think, I can't remember who it was. I think it was Greg Norman that said it. If he could go back and do it again, he would have done more slow motion and even mirror work and just without hitting balls and just practicing things in his swing that he and his coach felt he needed to, as opposed to doing it while hitting balls.
Yeah, I mean, it's right that the pros, that I don't know how many balls they'll hit, in between tournaments. I mean, but they're practicing and practicing and practicing. If it's the hundreds or a thousand, I don't know, but it's a huge number.
Mm-hmm. I always say that the greatest, next great things are always coming from the periphery, because usually those on the inside are focused so much on what they're doing, and if you're doing some things repetitively, it's very difficult to get out of that routine and think well outside the box, which is usually where something has to come from. And I was listening to a discussion the other day with Chris Summers, who was the U.S. Olympic coach, and it made me feel better, at least from my own, that my theory was somewhat correct. And that he basically spoke to that, to where he said, if everybody's working on something to be great, you've got to work on something that's the next great thing in order to beat all your contemporaries, or else if you're all doing the same thing, what's going to separate you? So the next great thing usually comes from way outside the modern conventional way of thinking. And so with that in mind, and given the history of the disc replacement as it came from, as you were thinking about it, and someone else had brought it forward, as well as a career of involved in spine and back treatment, what do you see as the next groundbreaking thing now that we're approaching 20 plus years for disc replacement? Is there
Well,
something that you see or have an
yeah,
inclination that might be the next big thing?
well, the next big thing is actually going to be on regenerating the disc. And, my alma mater at the University of Pennsylvania, they are already making scaffolds, and then they're injecting them with stem cells. So they're, making a disc with an annulus and a nucleus, and they're injecting them with stem cells, and the cells inside the nucleus part are making nucleus, and the part that are the stem cells injected in the annulus lattice work uh, are making the annulus, and which are slightly different structures, but they give us the biomechanical aspects of the disc. Which one, the nucleus is compression, and the ring gives us our twisting, like you're talking about the torque.
Mm-hmm.
They're arranged. There's 20 to 40 layers arranged at 45 degrees, so that allows us to twist without tearing up our spine. So they've done some experimentation in animals, and they've actually been able to make them. Now, there's going to be a lot of, things to work out. How are you going to put it in the human and things like that? But that'll be in the horizon. So right now we're doing these mechanical discs, and they may still be good for older folks that are so far degenerated. And it'll take a couple generations before we start treating people at a younger age with these devices. And also, we may find out that certain types of stem cells will help to regenerate an early degenerative disc. Now, there's lots of stuff out there. It's not regulated by the FDA. I have so many patients, professionals, non-professional athletes, you name it. They're all getting quote unquote stem cells. They're sucking blood out of their hip. They're spinning it down. They're putting the stem cells in. They're paying $3,000 to $5,000 for these injections that are totally unproven, but and they're probably not doing anything. Most of the time, it doesn't work at all. Placebo works 37% of the time, which means that you could, put just throw water in there and it's going to work.
That's
So,
interesting.
but so it is going to be a biologic solution for the early degenerative disc, and a biologic solution for the later degenerative disc. But it's going to take a while once we have that to clear out, those of us that have the really degenerative disc, because we're not candidates for be candidates for them.
Hmm.
And it's almost like scoliosis. Now that we have scoliosis screening, we do far less scoliosis than what we used to do. And also, we're finding out that genetics have a role too.
Yeah, I as I watch the things in the back world from afar is the I think it was when they were inserting either the balloons or the gel in between to try to ease
Oh,
the
yeah, the
differential of the
disc
vertebrae,
is,
that really
yeah,
never took off the
it
way that
never
thing was
took
sold.
off, and there were a million of them out there. But that's how you progress goes forward. People have to try things and prove that they work, they don't work, and then you go the next phase.
I've got to ask you, with all you do with the lecturing in a, we'll call it a normal, or what used to be normal world, the lecturing and the traveling and the research institute and the surgery and your family life, how do you manage to balance it all out?
It's hard. Don't ask my wife, but I do. I mean, yeah, you know what? You learn to compartmentalize when I come home. During the weekdays it's hard because I do a lot of work, and we're doing this. Have Zooms that I do during the week, but on the weekends, that's when I recharge my batteries. We have a little lake house, and we just go down there. It's in the middle of nowhere, and I just like looking at the lake and watching the birds. And so you have to have some happy place where you can recharge your batteries. So
Hmm.
that's going. So, you know, before COVID, I used to travel a lot, and now I do a lot of Zooms. The traveling is going to start to pick up, at least inside the U.S., not out so much outside the U.S. But I try to maintain a balance. I love my family, I love my kids, and we try to have quality time. And my wife gets mad at me because like we're having some friends over for New Year's, and she's asked me all sorts of questions about what kind of food, and she has her friends deciding, and they're all in the same group text, and do we like this? And finally, I had to take myself out the group text, and Shelly said, "Well, why do you do that?" I said, Shelly, I make so many decisions during the day. I have so many people that are asking me a million things. I'm explaining to patients. I'm answering questions of the OR, my nurses, and whoever else. I said, I make decisions all day long. When I come home for these kind of things, I don't really care. I'll take whatever you guys give me, but I don't want to have to make any more decisions. That's somebody else's job. My job is to at work. I'm making all these other decisions. So
It's good. I think you like photography. It's got to be a good getaway for you, just quiet and looking.
well, you bring up a really sore topic. I have pictures in my exam rooms, and patients always say, "Well, where's that from? And where's that from?" And I really like talking about it. That sort of breaks the ice with them. And I always make them try to guess where it is. And they say, "Why don't you put names up?" I said, "Because I want you to look at it and try to figure it out."
Hmm.
And but anyway, so yeah, I love traveling. And when I would go to lecture, I always, would take my camera with me and take pictures. But my camera, I had to take it out the other day, make sure it still worked, and replace the batteries. But no, that's a sore spot. I can't wait to travel again.
What's next for you? Is with all you've accomplished and are doing. What's the next chapter for Dr. Geyer?
The next chapter is just to keep on doing what I'm doing. I'm gonna, keep on teaching the fellows, lecture, travel with lecture. Hopefully, I can travel outside the U.S. We love traveling, both my wife and I. So I'm just going to keep on doing what I do. And like anything else, you get better with age and get wiser. And you know, not to say that a young surgeon doesn't have very good skills, but you do get better, and the judgment helps you as well. And the more you see and do, the better you get. So I'm not changing a thing.
It's good. All right. You want to? Usually do a rapid fire. It's emergency 9. I call it 9 questions to wrap up with. Or do you have a time to do that, or
Sure,
do you need to get
let's
running?
do it.
Okay.
Let's do it.
This one's on everybody's list. And it's kind of fun one to have. So if you were gonna play golf and you made the Ryder Cup team, and now they play a song as you walk up to the first tee, what would be your Ryder Cup walk up song?
Oh God, it might be the Rocky song, where he runs up the stairs.
Right. That'd be pretty cool. That's the first time I heard that, but that is a very cool song and very
Oh,
appropriate for
now,
that setting. Let's see. The last book that you read. Always curious to hear what people are reading.
Oh, the last book I read was it was a Jack. Oh God, I'll tell you in a second. It was about this guy is a retired Navy SEAL, and he is a fantastic writer. And he has written a series of four, and just sort of mesmerizing. His name is Jack Carr, and it
Mm-hmm.
was called True Believer. I like this kind of books. Once I get into them, I can't stop reading them. Some books I start and it takes me forever. Like Red Notice was a book that took me forever to get started, but that was a great book too. But the most recent one was the True Believer, Jack Carr, and that's the second in the series of four.
I'll have to check that one out. I like to read it just is to get away from the monotony of
Oh,
daily.
absolutely.
Let's see. If you could play a round of golf with any three people that you throughout history, who would they be?
Well, if I was any good, I mean, I would pick Jack Nicklaus, Arnold Palmer, and Tiger Woods.
I think you'd have a fun time in that group.
Yeah.
If they came to you and Hollywood came to you and said they wanted to make a movie about your life, who would play you?
Oh God. um, Certainly not Tom Cruise. He's too good looking for me. I don't know. That's a toughie.
We can go with Tom Cruise. I'm sure Mrs.
Okay.
would appreciate that one. Your superpower, what would it be?
Oh, my superpower, it would be to fly.
Like a pilot in an airplane, or to have the ability to fly like Superman.
So just for me to be able to fly.
That'd be pretty cool. When I was a kid, I used to have a lot of dreams that I would fly, and I agree. I think that would be very interesting and unique. Let's see, just a couple more. If you wouldn't have become a surgeon, what would you have been?
A jet fighter pilot.
Right in line with the flying too.
Yep. Because they think like surgeons do. Their job is 99% routine and then 1% terror. I'm just amazed at how they can, be in the dog fights and taking care of a lot of fighter pilots. I love those guys. I love what they've done for our country, but I just have a lot of admiration for what they do because it's a skill set that is sort of innate. It's almost like an athlete or like a surgeon that has certain skills, and it's hard to define it. Some people have it, and some people don't.
Mm-hmm.
But they have the ability to have this imaging when they're up in the sky, traveling at 700 miles an hour with another plane approaching or another one on their tail. So that's what I would have been.
Yeah, as you mentioned that on this very similar between pilots and surgeons and routines. That was one of my favorite books. Was the Checklist Manifesto.
Well, listen, we learned a lot from the aeronautics industry and in surgery. We have it's called a timeout. Everybody's got to the patient. We got to talk about what we're doing on the patient, what side we're doing it
Mm-hmm.
on, and everything. So yeah, we've learned a lot from the aeronautics industry.
Yep, that whole book, Doctor, I think Atwal Gawande was the one that wrote that, and learned a lot from pilots and what the checklists and how they do things, and they took that into the surgical room and basically, I mean, they wrote the book on how to do it, and it's been. I'll try to send you one if you haven't read that. That would be a bit, well, I mean, you lived it and you deal with it
Well,
daily.
when I was president of North American Spine Society, I think, well, when I was coming up through the ranks, we had the author of the book come and talk about it, and yeah, it's just amazing.
Mm-hmm. Would you rather talk to all animals or speak all languages?
Oh, wow, I love animals. Wait, what was that? Would I like to speak all
To
languages or talk?
talk to all animals, or you could speak all languages.
I'd rather talk to animals.
I'm with you. I don't want to talk to too many people. They start
Yeah,
asking for things.
I'd love to know what my male dog is thinking. He's 13 years old. He's a beautiful Westie. And sometimes he looks at me and I'm thinking, Max, what are you thinking about?
Probably thinking, "What's for dinner?"
Yeah.
Let's see. And in your opinion, and you might be biased in this one, but the greatest golfer of all time. Everyone gets the first question and the last question. So, who do you think is the greatest golfer of all time? As you've transversed the eras to where those candidates would have played. You've
Oh,
seen them all.
I think probably Nicholas is the greatest golfer, but I have a bias, and because of my previous experience, I think I'm hoping that Tiger can come back and to break all records. I think that if Tiger, didn't have, some of his tumultuous times,
Mm-hmm.
back in 2008 and all, he could have clearly been the greatest golfer of all time.
Yeah. Did you? We briefly mentioned him and Charlie earlier. It was very nice to see him play this past weekend, and
Yeah,
I
I
think
mean,
everybody wants to see him come back and participate again.
yeah, I mean, and I took a picture of he and Charlie, and what greater thing is it to have your son, following your footsteps. And Charlie is really good. I mean, I was impressed with him. Oh my God.
Mm-hmm.
I mean, how he was hitting the ball and his putting. So anyway,
Um, any books or lectures you have coming up that we can tell people about that they can go buy or sign up for or watch
um,
that you have in the near future?
well, we have the Seattle Science Foundation. We do an arthroplasty meeting that I think is coming up. It probably the second or the third Tuesday in January. It's not a lecture, but we have a panel, and I'm on the panel that we used to do it every month. Going to do it every 3 months. I'm going to Vegas to talk about artificial disc. I don't know that anybody wants to come to that. That's the second week of January, and then I have a couple meetings one in May, two in June, where I'll be lecturing as well. But they're for different society meetings.
Well, if you really want to irritate the hell out of yourself, write a book. I'm sure there's many people out there, myself included, who would be in line to buy it, but it would the people I've
Well,
talked to who've done them.
I thought about doing that. The other day, I think about a lot of things, but the other day I was getting up for surgery, and patients always kid me. They say, "So, doc, you're not going to go out and party tonight?" I said, "Oh yeah, I always go out and party and drink a lot." But no, and tomorrow I have a big day, so I usually go to bed on time, and I wake up and I just have my usual breakfast and everything, but I like to listen to some of the news, but on surgery days, I listen to music because what it does is sort of gets me in the frame of mind.
Mm-hmm.
And just like sports, I think that surgery is also, there's a lot of mental to it as well as having the talent. And you see that in athletes. And an athlete is like off mentally, they suck. Your football team looks terrible, like my Cowboys. If they just don't play well. So anyway, so I thought about, writing a book, The Real Life of a Surgeon, because people don't understand what we go through. They think, oh, a surgeon's great. They make lots of money, but they don't see the anguish you go through if a patient doesn't do well or you have a complication. And, it's during those times where you say, all you care about is the patient doing well, and you go over in your mind, what could I have done better, and so forth. And all the money in China would not make you feel better. And I've had my partners, and I've gone through the same thing. You start to feel worthless, and you think you're not a good surgeon. Maybe you should have changed your profession. But I'm old enough now to know that that's silly. But when I was younger, I used to feel that way.
Oh,
And,
I mean, I do that when a student doesn't play as well as they want to, or I think they're capable of. And I mean, I now you're talking about somebody's livelihood, what you're referring, with somebody's back
yeah.
surgery and their enjoyment of life. I couldn't imagine the racking of the brain that the beating yourself
Oh,
up.
and listen, we as surgeons torture ourselves, and any good surgeon. I would say a surgeon that is is in it for the wrong reason and doesn't care about his people, he doesn't get bothered. He's a complication. And I've had surgeons that, just rolls off their back like water off a duck's,
Mm-hmm.
back. So Anyway, so I've thought about doing that, but I don't know if I'll do it. But I got too many other things I want to do.
Well, every time I talk to you, you exceed your impeccable reputation. And it's always a pleasure. If somebody wanted to get a hold of you, is the TBI website, which I will have linked into the summary that people can click on and go right to y'all's website. Is that the best way for someone to contact you if they want care or for something?
Go to rgeyer@texasback.com.
Okay. And I'm sure that they will get in touch with Jennifer, and as wonderful as she is, she will take it from there.
Yeah, Jen is great. Well, Pete, it's been a lot of fun. And listen, I wish you a Merry Christmas and a Happy New Year. I don't know if you got to filter this out or, edit this out.
No, you and your family the same. I wish you all the best. And I'd love talking to you. I just hope that it doesn't have to be in a telemed. I hope we can have conversations in the future just about general things again. In person, that's right.
All right, Pete.
Thank you. You have a wonderful evening. All right, everybody. Thank you so much for listening to today's show. If you enjoyed it, you can find more information on today's episode and other topics at golf360.blog. There you'll find the show notes and links related to this episode, as well as any other episode that we've done so far to date. If you're interested in improving your game and would like to learn more from yours truly by taking a private lesson, a half-day or multi-day school, club or putter fitting, you can reach me through the blog site or by email, pete@golf360.blog. So some of you may be asking, what is the golf paradigm? All you have to do is click on the homepage while on my blog site to discover how you can start playing better than you ever thought possible. Or you can simply sign up, again, on the blog page for my instructional videos where I give regular tips on all areas of the game to include the swing, club design and fitting, health, fitness and nutrition, the mental aspects, and equally as important, the integration of all those things together. I'm also on social media, and you can find me at The Golf Paradigm. That's PARADIGM. And I'm on Facebook, Instagram, and Twitter. And don't forget to subscribe to my YouTube channel, also under the same name, The Golf Paradigm. Facebook is usually the best way to reach me for questions and or comments, and I look forward to hearing what all of you have to say. This podcast is brought to you in part by Old South Golf Links. A short ride across a bridge from Hilton Head Island is one of the area's finest golf courses and a hidden treasure. Set up on towering pines and ancient oaks with sweeping marsh vistas, truly makes Old South Golf Links a one-of-a-kind golfing experience. The Clyde Johnson design was named one of the top 10 new public courses when it opened, and it also takes full advantage of the natural beauty of the Low Country. Old South is a fun and unique challenge for golfers of every skill level and a favorite of both locals and visitors. Whether it's your first time here or you're a regular, you'll be treated and feel like family. From the bag drop to check-in at the fully stocked pro shop with both men's and women's apparel, to breakfast or lunch before or after your round, the staff is always ready and willing to help. Experience for yourself why Old South is one of the premier golf courses in the Hilton Head area and why it will quickly become a favorite of yours too. Visit them in person or online at www.oldsouthgolf.com, or to make it tee time, simply call the pro shop at 843-785-5353.